CardioOncology. A very warm welcome to all of you for joining our inaugural JACC CardioOncology Live Journal Club. Thank you for joining us today for this next hour, and I'm truly excited about all the learning that's going to be taking place. Today, we will be discussing 2 manuscripts for our June issue. These 2 original research papers really represent the diversity of topics that are important to us as a journal as we seek to advance the field of cardio-oncology. They provide new data on both conventional therapies such as anthracyclines, as well as novel therapies such as CAR T-cell therapy, and helps us to keep pace with the evolving landscape of cancer therapy. Today, we're accompanied by a very esteemed group of authors and editorialists, Dinesh Davandaranathan, Candace Silversides, Matt Earhart, as it relates to the impact of cancer therapy-related cardiac dysfunction on the risk of heart failure in pregnancy, and also Benedict Lefebvre and Mariel Scherer-Crosby as it relates to the cardiovascular effects of CAR T-cell therapy. We also have a wonderful group of panelists today comprised of members from our editorial board, including Sara Omenian, Ron Watellis, Katie Ruddy, Ann Blaze, Andrew Noria, Ludmila Hajar, and Tom Nealon. We have today over 230 registrants and friends from our community here with us. So if you have any questions, please enter them on the side, and Dr. Hajar and myself will be monitoring these. So let's go ahead and get started. And Dinesh, will you please take it away?
Thank you, Bonnie. Just waiting to get the ability to show. Perfect. Okay, good morning, everyone. Thank you very much for the opportunity to present our work. I'm presenting this on behalf of all the co-authors listed at the bottom. I'll start off with some background. In 2020 itself, in the United States, there'll be over 100,000 new cancers diagnosed in children, adolescents, and young adults. Fortunately, with significant improvement in therapy, more than 80% of these individuals are expected to survive well beyond 5 years. As a consequence, as of January 1st, 2019, there are over 600,000 AYA cancer survivors in the United States. These individuals are at a higher risk of multiple comorbidities. Cardiovascular disease is an important contributor to mortality and morbidity in these survivors. Approximately a third of these patients may have subclinical cardiovascular disease. This can progress onto clinical cardiovascular disease with the second hit. The second hit may be traditional cardiovascular risk factors, or particularly in women, it could be physiological changes related to pregnancy. This includes increased plasma volume, physiological anemia, as well as cardiac output, all of which contributes to increased wall stress and potential decompensation. These changes last up to 6 months post-delivery. So the objective of our work is to perform a systematic review and meta-analysis of published studies to quantify the impact of pre-pregnancy history of cardiotoxicity on the risk of maternal left ventricular systolic dysfunction or heart failure during pregnancy or within 12 months of delivery. Here are our methods. We performed electronic search using 2 different databases in appropriate terms. We included prospective and retrospective studies that consisted of women with prior cancer diagnosis having been treated with cardiac functional status known pre-pregnancy. Patients were followed from cancer diagnosis until first pregnancy, and our primary outcome was LV systolic dysfunction or heart failure during pregnancy or within the 12 months. We excluded non-human studies, abstracts, and those in non-English literature. All papers were reviewed and data extracted by 2 authors, and authors of the primary manuscript were contacted for additional data. Here are our results. We identified over 13,000 articles, of which 6 met inclusion criteria. All were deemed to be of good quality, majority retrospective, and constituted 2,016 pregnancies. Median age at cancer diagnosis was 12. Median age at pregnancy was 21. Cancer treatment occurred between 1963 and 2015. Majority received anthracyclines and had hematological malignancies. Here are our main results. 2.9% of our patients developed left ventricular dysfunction and heart failure. 32 out of the 33 received anthracycline-based therapy. On the left-hand side of the screen, you see weighted incidence. The overall weighted incidence of our primary outcome was 1.7%. However, in patients without a prior history of cardiotoxicity, it was 0.24%, while it was 28.4% in those with prior history of cardiotoxicity, translating to a number needed to harm of 4. On the right-hand side, you see a forest plot summarizing all the individual studies. Patients with a prior history of cardiotoxicity had a 47-fold increased risk of left ventricular dysfunction or heart failure. There were no publication bias identified. Our meta-regression showed there were no changes to the risk estimate based on the publication year, anthracycline dose, or the patient number in each of the studies. Our study is not without limitation. There were a limited number of events from six single-center studies. Patients were treated over a broad time span. There were inconsistent definitions of cardiotoxicity. There was underrepresentation of older cancer survivors, and we were able to adjust for some of the high-risk baseline characteristics, such as stopping cardiac medications in those with prior cardiotoxicity at the time of pregnancy. This final slide summarizes our results and an approach to pregnancy in cancer survivors. Those who have received potentially cardiotoxic cancer therapy with a prior history of cancer therapy-related cardiac dysfunction are at a significantly high risk of decompensated heart failure during pregnancy or early in the postpartum period. These patients should be considered for specialized pregnancy care. Those without a history of cancer therapy-related cardiac dysfunction following current guidelines should have an assessment of their ventricular function, considering some of the variables in the blue box that increases risk. If there is left ventricular dysfunction, these patients should also be considered for specialized pregnancy care. If their ventricular function is normal, these women could be reassured that their risk of maternal cardiac complications is quite low, but they still would warrant routine pregnancy care, maintaining vigilance for potential maternal cardiac complications. Thank you.
You who are just joining, Dinesh Davindaranathan just presented a brief synopsis of his paper in our June issue, Impact of Cancer Therapy-Related Cardiac Dysfunction and Risk of Heart Failure in Pregnancy. And I encourage you all to attendees to answer questions or ask questions on the chat function, on the Q&A function, on the WebEx. Dinesh, that's a terrific study. I wanted you to give us some context and talk to us about what motivated you to execute this analysis, and tell us a little bit about the quality of data and the necessary components in your viewpoint to execute a high-quality meta-analysis.
Motivation to do the study is really the spectrum of patients that we care for at our institution. Now, we are right next to a pediatric cancer center, so many of the pediatric cancer survivors, or AYA cancer survivors, are referred to our program, and we have seen many go through pregnancy. And when there's a question as to what is my risk of heart failure in these patients and what are the risk factors, often we had no answers. So this really motivated us to go back and look at the literature. And there's been some great studies in the literature published by some good groups. But the challenge is that putting all that together to come up with the risk estimate that we can provide patients was not available. And that was the major reason for us to do this meta-analysis, to come up with the risk estimate. The second reason was to answer the question of what are the risk factors. And often when I see these patients, we do have cardiac imaging data. Many of these patients bring their cancer therapy data, but that's not always available. They often know, at least their parents know, whether they have developed heart dysfunction before or not. So it was a variable or a piece of information that was universally available when I saw these patients, at least in our program. And this is what really motivated us to ask the question whether this history of cancer therapy-related cardiac dysfunction would be considered a risk factor for decompensation. And hence, that was the primary question in the meta-analysis.
Great. Thanks so much, Dinesh. And some questions that are coming through the Q&A, and I'd like to open this up to Candace, who's an expert in cardiobstetrics, who's a co-author on your work. Candace, one of the questions is there any increase in incidence of preeclampsia in patients who have received chemotherapy? as we understand from recent data that preeclampsia is actually a cardiovascular inability to cope with increased load.
Yeah, so that's a good question because there clearly is an overlap on a number of variables. We didn't look at that in this study. This study was looking at heart failure and drop in EF. There is no good data showing the association of preeclampsia and prior chemotherapy that I know, but I think it would be a reasonable question to look into because I think there is overlapping risk factors as well as the possibility of the effects on the vascular system with various chemotherapies. I could tell you just clinically from seeing these women, I wouldn't have right off the bat thought there's a clear association, but again, that's not a study, that's just my clinical sense, having seen a number of these women, that there's not a huge volume of them that are developing preeclampsia. But again, it needs to be studied properly.
Thanks, Candy. And I'd also point people to, at least as it relates to pericardium cardiomyopathy, a paper that we published in our December issue, suggesting that there's an increased link between cancer prevalence and pericardium cardiomyopathy from a genetic basis.
Yeah, and just, there is a very well described association between preeclampsia and pericardium cardiomyopathy. So you can see the links are kind of there. It's just, I think it's a study waiting to be done well.
Thanks, Candice. Matt, you wrote an editorial with Melissa Hudson on this piece. Talk to us about your perspective and the incremental value of these quantitative estimates on how we treat cancer survivors.
Yeah, thank you. I'm happy to join the call today. Both Dr. Hudson and I thought this was a very good study and very timely. We're heavily involved, as are a number of the panelists here today, with the Children's Oncology Group cardiovascular recommendations. And this is an area that we've really searched for in the past, and there have been very few studies, as evidenced by this review, that informed recommendations in this area. So the ability to do a systematic review and meta-analysis adds to the strength of those recommendations. As noted by both Dinesh and in the paper, the small sample size of these studies makes the individual studies difficult to make strong recommendations from. So we're highly supportive of the algorithm that came out of this manuscript, and we think that it really helps, as noted, for those individuals that are assessing these patients in clinic. Often you don't have a cumulative anthracycline dose, so knowing that that baseline echocardiogram is either normal or abnormal can be quite informative when making recommendations for additional follow-up. And I would also highlight what's already been said, that we do need additional studies to help inform the management of these patients. So we've not seen data that suggest what heightened level of surveillance, for example, is necessary during the peripartum period, even in the presence of an abnormal echo. So more data to come in that area would be very helpful. But nice job on this study. It's very good.
Thanks, Matt.
Can I just make one clinical comment? Just about surveillance and just that clinical matters, because that's what I do. There are great guidelines by the European Society of Cardiology who do address cardiomyopathy, and probably these women fall into it. I think there'll be nuances in this population, but there is a very good set of guidelines that provide information about surveillance. And just as a reminder, the hemodynamic burden of pregnancy peaks in the third trimester. So most of the time, heart failure or drop in EFs occur late in the pregnancy or early postpartum after they get fluid mobilization. So although I agree we don't have anything specific to this population, I think there are some good guidelines that at least could act as a starting point for this population for those of you that are caring for these patients.
That's a really nice clinical pearl, Candice. Thanks so much for sharing that with us. I wanted to also open up to a few of the folks on our panel. Anne, did you want to make a comment about older cancer survivors, and then next I'll ask Saro to comment a little bit about screening and the Lancet harmonization guidelines.
Thanks, Bonnie. Yeah, thanks, Bonnie. I just wanted to, the article is really, really well done, as we've discussed, in an area that we don't have a lot of data in. I do think it's important to mention the median age. These were mostly childhood and young adult survivors based on what's currently available in the literature. So when we see a lot of young breast cancer survivors who go on to have pregnancy, we haven't really addressed sort of what their risk is. I think this is the best literature we have right now. It's important to note there's two large studies, one that was presented at ASCO last year looking at pregnancy and BRCA patients, patients who have a BRCA mutation who go on to have pregnancy, and the risk of complications. They did not specifically look at cardiac dysfunction, but the risk of complications was comparable to the general public. And about 95% of those patients had received chemotherapy. And I think there's an ongoing registry called the Positive Registry study that is looking at these young breast cancer survivors who go on to have pregnancy. So it's something just to keep in mind. I really commend the authors on a great review. I hope with time we'll have more information about our slightly older cancer survivors who go on to have pregnancy as well.
Thanks, Anne. So did you want to make a comment about your work and Melissa Hudson's work? Like, she has also joined in the Lancet harmonization guidelines and screening.
Yeah, I'll just very briefly just say that that there was and it continues to be an international effort to harmonize recommendations for long-term surveillance for these patients. So back in 2015, when we had our first cardiomyopathy harmonization effort sort of come to light, at the time there were only 2 studies that really addressed the issue of pregnancy. And what's really wonderful is that since then there have been 4 studies that have added all together to the 6 that are being reviewed. At the time, the recommendations around pregnancy and surveillance was really low level of evidence, so it was level C. In terms of what we should do. But what I would definitely say that this study has clearly pushed that up to a much stronger level of evidence and much stronger recommendations that we're going to be able to make. And it's quite reassuring that for patients who have, or survivors who have normal cardiac function prior to their pregnancy, that routine surveillance is what we'd recommended, because sometimes it's about doing less and not doing more. So that's really a fantastic addition to the literature.
Thanks, Saro. Melissa, I see you're on. Do you want to talk to us a little bit about risk factors, and then maybe Dinesh can also chime in after that about risk factors for dysfunction and your observations and your work and CCSS that have helped to inform that. And Dinesh can chime in after that about the risk factors for dysfunction or that he discovered or he uncovered, or he tried to look for in that analysis.
So can you hear me now?
Yep.
Okay, good. I wasn't sure. I tried before to make a comment. But far and away, the most important risk factor in this population are those women who have dysfunction, have a history of dysfunction. And pre-pregnancy or when planning pregnancy, establishing that is important in an effort to direct care. If we're targeting women who have normal systolic function that has been evaluated through serial risk-based screening, we know that the risk is quite low, although we would want to keep an eye on women who have had high-dose microcycles, specifically more than 250 per meter squared.
So certainly prior history of cardiac dysfunction as evidenced by Dinesh's work, and those who have received high doses of anthracyclines, again, for everyone, that's considered to be greater than 250 mg per meter squared of doxorubicin equivalent. Dinesh, do you want to comment a little bit about the work that you were trying to elucidate and other risk factors in your meta-analysis?
Yeah, thank you, Bonnie. And thank you for everybody's positive comments about our work. We appreciate the feedback. So just looking at individual risk factors, and that, initially we started off saying, can we identify risk factors beyond cancer therapy-related cardiac dysfunction, and can we combine that together and potentially provide estimates for each individual potential risk factor? We noted that they were not consistently available. The same variable wasn't consistently available in all the studies for us to be able to put the data together. As Dr. Hudson mentioned, a total anthracycline dose was identified as a risk factor, at least in 3 of the 6 studies. 2 other risk factors that were described were younger age at cancer diagnosis and longer time from cancer treatment to pregnancy. Now this may reflect 2 things. One is younger age perhaps reflects the larger susceptibility of a growing heart to potentially cardiotoxic cancer therapy. Alternatively, the longer you are away from the cancer therapy, my feeling is that the longer time you have for a second hit, whether that's hypertension, obesity, physical inactivity, or something else to happen. And hence, you have accumulated multiple different insults by the time you become pregnant, the longer you are away from your cancer therapy, and perhaps it makes you more susceptible to having decompensated heart failure. The last risk factor we identified, at least in one of the studies, the current use of cardiovascular medications. I wonder if that's just a surrogate of patients who have comorbid conditions that increase the risk of subclinical cardiomyopathy, or perhaps a subgroup of patients with prior cardiotoxicity who are still on treatment at the time of pregnancy. And that may be what current use of medication reflects as a potential risk factor.
Thanks, Dinesh. And I wanted Anju to also comment on radiation a bit. Anju, you see a lot of patients with radiation survivors who have been exposed. Tell us a little bit about what you've seen in terms of radiation as a risk factor in this population.
Thanks, Bonnie. I also would like to congratulate the authors on a really well done meta-analysis. I think the same holds true for radiation patients. They can also have marginal EF and may not have overt heart failure, but could be susceptible to developing heart failure in the context of the volume load of pregnancy. Often what we do clinically is do a stress echo and look to see if they have adequate contractile reserve prior to their wanting to become pregnant, beyond just looking at the EF at baseline. And often if they have diminished contractile reserve by that modality, then we may counsel the patient to be a little bit more cautious and to have more testing done during pregnancy, usually at the end of the 2nd trimester or the beginning of the 3rd trimester, and then also informing them about the symptoms that they should watch out for either at the end or immediately after delivery. Actually, one of my questions for the authors was, I know that in the meta-analyses, there was no, in the studies that we included in the meta-analysis, there were no criteria to define CTR-CD, and many of the studies used an EF less than 50 on 2 subsequent echoes as the pregnancy endpoint. So if someone has an EF of greater than 50 to begin with, or it's in that low normal range, like how are we defining who we should be considering high risk for the degree of surveillance that you're recommending in your central illustration in this paper?
Struggle with lower thresholds for normal versus abnormal generally in the field of cardio-oncology. And I'm not sure if there's a good threshold to use. And like you said, it hasn't been clearly delineated in the studies. Our general principle has been just to use the lower limit of normal as recommended by the American Society of Echocardiography, which is 54% for women. So that's the threshold we use to identify abnormal ventricular function. And for us, those patients who have abnormal ventricular function defined by the criteria will be followed in Dr. Silverside's clinic through the pregnancy, or patients who have even worse LV dysfunction or heart failure would be followed in a clinic as well. So we use that 54% threshold. And I think you're absolutely correct. We'll probably need to look at this prospectively, and we are doing that right now to see if we can further define, subclinical cardiac dysfunction by other measures, or the threshold ejection fraction that actually identifies increased risk that's the study ongoing. Hopefully we'll have some answers.
Great, thanks, Nash. And that does answer one of the questions on the chat about how cardiac dysfunction was also defined. Ron, I know you've been communicating with Eric about some notes about peripartum cardiomyopathy. Do you want to just talk about this and share some of your thoughts about peripartum cardiomyopathy in cancer survivors?
Yeah, sure. Thanks, Bonnie. I'll first add my congratulations as well to the authors of the study. I think it added to an obviously understudied area and is a good use of meta-analysis when you have just a few very small studies and disparate studies. In terms of the peripartum cardiomyopathy, certainly my own observation is that many patients get labeled or mislabeled with peripartum cardiomyopathy, which is a really distinct phenomenon. It's not meant to be referring to patients who have pre-existing cardiac dysfunction who then become symptomatic in pregnancy because, as we heard earlier, about the hemodynamic changes that happen during pregnancy and then immediately postpartum. So, for one, I suspect that from my observations, a non-trivial number of patients who get mislabeled with peripartum cardiomyopathies are actually women who have had previous cancer therapy, particularly anthracycline cancer therapy, and just get that label to go along with things like obvious familial cardiomyopathies when you take a family history or history of methamphetamine use, et cetera. And then you say, well, no, this is just when they became symptomatic. And it's often also the first time that they really encounter medical care for many years or maybe since childhood. There was a question about bromocriptine, which is used in Europe a fair bit for peripartum cardiomyopathy because of the belief that prolactin causes it. I think the jury's still out on that, but I don't think there'd be any role of using it from a chemotherapy-related cardiac dysfunction. Where again, I think probably everybody's seen here this is just unmasking subclinical cardiac dysfunction.
Thanks, Ron. I'd like to open up to Ludmila and then Katie just for some additional comments. Ludmila, tell us a little bit about your practice patterns in Brazil and so forth. Ludmila?
It's a great study. I think this adds new comments and new innovation to the field. I'd like to ask Dinesh, how could you think about a strategy to prevent this heart failure in these patients, considering that you found a very high risk of heart failure during pregnancy in these patients? How could you think about the strategy to prevent it?
Ludmila, thank you for the question, and thank you everyone again for the positive feedback. A challenging area, and I think this may be something that I may push over to Candice as opposed to how they deal with peripartum cardiomyopathy. I think this area is quite controversial, so I look forward to any suggestions from her. Candice?
Well, I could just tell you in cardiomyopathies in general. First of all, I wanted to say I agree that a lot of women are called peripartum cardiomyopathy that are probably just adriamycin exposure in the past. That's been my experience over many years of doing this, is that they get mislabeled. So I definitely agree with that. Secondly, though, regards to prevention, I mean, I think cardiomyopathy, perhaps specifically here, but even in general, anything we can do to protect the ventricle. The problem is during pregnancy, you can't use ACE, ARB, or spironolactone because of the adverse fetal effects. So you're really left with a pretty limited options. We use beta blockers all the time for many things, including hypertension, arrhythmias, and cardiomyopathy. So I think beta blockers are probably the most reasonable starting point. And certainly when I have anybody with a significant cardiomyopathy, many times they're on a beta blocker, but even if they're not, my preference is to have them on it. Again, that's not with data. So you really have to go into it really informing the patient, explaining the fetal effects of beta blockade, and making sure that they're on board. But certainly if they have significant LV dysfunction, I think your hands are fairly tied. And then if not, you follow them closely. If they do get heart failure, you can afterload reduce them with hydralazine and nitrates. But, you know, we don't have a lot of options. Statins haven't theoretically been used in pregnancy, although there's a growing body of literature using statins for preeclampsia. So There's a little bit of things coming, but I would say probably the only real clinical option right now is beta blockers and then close surveillance. And if you do develop a drop in EF, to kind of up your ante and add more meds if it's feasible.
Thanks so much, Candice. And Katie, did you want to make some comments or have any questions? And while Katie's speaking, and if perhaps Benedict can upload her slides as well for our next manuscript.
This has been an excellent discussion, and I appreciate having heard from this multidisciplinary group. I'm a breast oncologist, so I'm actually seeing in a couple of weeks somebody who received ACT 2 years ago and now wants to take a break in her endocrine therapy to try to become pregnant. And so I think that these data really will help inform my discussion with her, although I echo Dr. Blaise's comments that, of course, we'd love to get more data on pregnancies in women in their 30s. I think it was only a very small proportion of the patients that you had included had a history of breast cancer, and that's probably contributing to those young ages of pregnancy where our patients are often getting pregnant in their late 30s or even early 40s. So I don't think I have any questions further, but I would applaud the authors and the discussants.
Thanks so much, Katie. And you're absolutely right. Just speaking to this, the very multidisciplinary nature of cardio-oncology itself, and also even cardio-obstetrics, and really just calls to the need for all of us to work together and communicate together to each bring our areas of expertise to take the best care of patients. I feel like we could talk for hours and hours, but I wanted to give Benedict Lefebvre an opportunity to present her paper and with Marielle Sherrill-Crosby.
Thank you. Just one moment. Am I still mute? Oh, I'm sorry, I couldn't find. Thank you very much for the kind introduction, and thank you for the opportunity to present on behalf of all the co-authors on cardiovascular effects of CAR T-cell therapy. So what are CAR T-cells? It stands for chimeric antigen receptor T-cells, and these are engineered patient-own T-cells to target antigens expressed by tumor cells. The structures include an extracellular antigen recognition domain that is fused to an intracellular T-cell receptor signaling domain. And once the CAR T-cell sees an antigen, it becomes activated, it proliferates, and it kills. It is now FDA approved for refractory CD19 positive antigen malignancies, so acute lymphoblastic leukemia and diffuse large B-cell lymphoma. And really, it was really a revolution in the field of oncology, being so efficient in these very hard populations to treat. One of the main side effects using activated T-cell is cytokine release syndrome. And fever is always there. And then according to the degree of hypoxia and also of hypotension, grading is done. So the objectives of this study was to define the occurrence and the natural progression of major adverse cardiovascular events in adults treated with CAR T-cells, and to assess the relationships between clinical factors, echocardiographic parameters, laboratory values, and cardiovascular outcomes. So the methods were, the study was performed at the hospital of the University of Pennsylvania, and was a retrospective study where all patients treated with CAR T-cell, either with experimental or with commercial use, were included. Baseline clinical, laboratory, and echocardiographic parameters were gathered, and MACE were defined as cardiovascular death, arrhythmia, somatic heart failure, acute coronary syndrome, and intracranial stroke. For the statistic, the univariable and multivariable cost proportional cause-specific hazard regression was done, and everything was verified with a backwards elimination. So 145 adult patients treated with CAR T-cell therapy were included, and the median age was 60 years old. Majority were male. There were patients with acute lymphoblastic leukemia, diffuse large B-cell lymphoma, and the majority had chronic lymphocytic leukemia, and that was a part of the experimental use of CAR T cell. Of these, 104 patients had cytokine release syndrome, so 72% of our population, at the median time of 6 days. There were 61 deaths, and 2 of these were cardiac, and the median follow-up period was 456 days. For MACE, we had 31 patients, so 21% of our cohort that had MACE, with 41 events. The median time to MACE was 11 days, and there were 22 heart failure, 15 arrhythmias, and the majority were atrial fibrillation. There were 2 acute coronary syndrome and 2 cardiac deaths. 55% of the MACE patient had another echo during the event, and their LVEF decreased from a baseline of 62% to 49% during the event. And the median follow-up period was 753 days. To your right, you have a Kaplan-Meier curve of MACE, and it was 17% at 30 days and 21% at 1 year. Univariable analysis revealed that 11 parameters were associated with the occurrence of MACE, and there were conditions such as atrial fibrillation, cardiovascular treatment with aspirin, statin, and insulin, the cytokine release syndrome grade, vital signs including diastolic blood pressure, laboratory values with hemoglobin, platelets, and creatinine, and signs of diastolic dysfunction with the mitral E over E prime and left atrial volume index. And by choosing only 4 variables in order not to overfit the model and choosing parameters that were pertinent for our population, with multivariable Cox proportional cause-specific hazard regression, we ended up with 3 significant parameters. And these were baseline creatinine, cytokine release syndrome grade 3, and cytokine release syndrome grade 4. So in conclusion, we were able to demonstrate that patients' characteristics are associated with future MACE, and these were the baseline creatinine, the cytokine release syndrome grade 3, and the cytokine release syndrome grade 4. Cytokine release syndrome occurred at the median time of 6 days, and MACE at the median time of 11 days, showing the temporal relationships in between these 2 important events. Thank you.
Thanks so much, Benedict. Mario,
hello, can you hear me? Great. Yeah, thank you very much for allowing us to present our work. So, the most interesting finding is probably this relationship between cytokine release syndrome and those events, which are mostly, as you could see, heart failure. Now, there can be at this point, only speculations on, why this relationship exists. And it's been shown, obviously, that some of those cytokines may be directly toxic to the cardiomyocytes. And I think Tom Nealon can certainly talk about this more in detail. And there is also, obviously, the possibility that the cytokine release syndrome itself is accompanied by vascular leakage, which can by itself, produce some symptoms of heart failure. And there are some other theories, and all this has also been very nicely summarized in a review by Arjun Ghosh that has been published in the JACC CardioOncology, the issue before this one. There is also a possibility that this is linked to a sort of Takotsubo-like syndrome. The few patients in whom we had follow-up echoes later on, after the initial echo during the MACE, which showed a decrease in ejection fraction in those who had an echo, tended to show some reversibility. So that, could also go with this theory, obviously, of Takotsubo, but these are only speculations. So those are the comments I wanted to make, and thank you very much.
I wanted to open up to Tom Nealon. Tom, you published a paper in the December issue in JACC describing the abnormalities in cardiovascular biomarkers and adverse cardiovascular events in this population of patients and defining relationships between cytokine release, troponin, and TOSI. Tell us a little bit about your findings and tell us about your impressions of this work, how its significance, approach, and impact.
Well, thanks, Bonnie, for the invitation. It's very kind of you and the team. Marielle and Benedict, lovely paper. It's slightly. I have the great pleasure of working very closely with Marielle, and however, it's really nice because our papers are actually say something relatively similar to each other, in that CRS seems to be intrinsically linked to the development of cardiac toxicity in both papers. The one additional thing we looked at was how administration of IL-6 antagonism affects the development of cardiac toxicity. And it seems to make sense that if you give an IL-6 antagonist relatively early, that you might actually reduce the cardiac toxicity related to CRS. A couple of other things I'd probably think about. It seems consistent that the development of CRS is the major driver of cardiac events and cardiac toxicity. The question I would think about, and both your results and our results have shown the same thing, is that the rates of prior cardiovascular disease seem to be higher in those folks who developed more injury and more cardiac events. Now, non-statistically in our group, primarily limited by sample size, but it would be interesting to combine data sets to ask that question, whether pre-existing cardiovascular disease is a risk factor, which it likely is. It makes sense because it's reduced reserve. And if that's the case, then the next question is whether seeing someone who's on this call will help reduce cardiac injury and cardiac events related to the administration of CAR-T. That's the first thing I would think of, is whether their screening and optimization of particularly high-risk people would help. The next thing would be whether the use of serial troponin will help. Benedict, you nicely showed the Lee index and for grading of CRS. As you know, there are multiple different indices for grading CRS. There's the Lee, there's the revised Lee, there's a few others. And one of the things I've often asked my colleagues is whether the addition of a pretty robust marker for injury like troponin would help stratify people in different categories of Lee index. And so if you had someone who maybe had, by Lee index, had grade 2, and you measured a troponin, would you be more likely to administer those folks an IL-6 antagonist? I think probably is the case, but it would certainly be worth testing. I think this space is going to get phenomenally complicated because people are just, the wealth of clinical trials in this space are remarkable. And so the combination between, there are multiple clinical trials out there where they're combining cyclophosphamide with CAR-T, doxorubicin with CAR-T, where they're combining PD-1 with CAR-T. If you can imagine that scenario, if you combine PD-1 with CAR-T, and you probably have at least 20 to 30% of those folks who get a newly detectable troponin, will present a lot of diagnostic challenges trying to decide who has CRS-mediated cardiac injury and who has an autoimmune-mediated cardiac injury. And the last thing I'd probably say is how this space has essentially highlighted some of the interventions that are going on now in the COVID world. People who, the clinical trials where they tested IL-6 antagonism in the COVID space were primarily based on the knowledge that was derived from the CAR-T space. When you read the originals, they say, in the CAR-T space, IL-6 antagonism is approved for reduction of cardiac injury in the setting of a cytokine storm. In COVID, there's a cytokine storm, so therefore we should logically test whether IL-6 antagonism in the COVID space works. And it all stemmed from work in the CAR-T space. So those are my comments. Thank you.
Thanks so much, Tom. Really astute comments, and I really love the concept of a risk-guided cardioprotection strategy with use of troponins potentially. But of course, that would take, as you alluded to, a lot of original research to bring that to light because of potential for false positives and so forth, and really take multidisciplinary efforts. And I think it's a call to everyone on this call actually to collaborate and come together. And it's also one of the missions of this journal to really help to incite further research. I have a question, and I'd open up to the panel for anyone willing to chime in. Do you folks think that CAR T is directly myocardial toxic, or is it the bystander of the cytokine release syndrome? Is there any evidence to support a direct myocardiotoxic effect on the vascular endothelium, or is it the cytokine release syndrome, or also even all the pretreatment that they've received? In both of your studies, a lot of patients received anthracyclines as well as other vascular toxic therapies. Tom, I'd open it to you, Anju as well.
Yeah.
There's two.
I don't think that this is the mechanism of injury is definitely different to PD-1 and PD-L1 and CTLA-4. I think that's what but that's just a theory and not supported by a lot of real robust data. The rationale for that theory is that when you look, there's a typical rise and fall of troponin in the setting of CAR T-related cardiac injury, whereas in PD-1 and PD-L1 checkpoint inhibitor-mediated cardiac injury, you develop myocarditis, and unless you do something about it, the troponin generally remains up. So the typical rise and fall suggests that this is a transient cardiac stress-related phenomenon rather than a persistent immune tolerance-related phenomenon.
Thanks, Tom.
So, Bonnie, I would agree with, sorry.
Go ahead.
I would agree with Tom that I think the pathophysiology here is very different. I think one of the shortcomings of the field is that we treat all symptomatic heart failure as a cardiotoxicity of this therapy, and there is very little serial echocardiography performed in these patients. So we don't actually know whether there is LV dysfunction associated with the symptomatic heart failure that you're seeing. And as both Tom and Marielle pointed out in the discussion in their papers, when these people have hypotension as a result of high-grade CRS, they receive high doses of volume resuscitation, and that alone could lead to volume overload that isn't really cardiac toxicity. So I think one of the big missing links in all of this data is the lack of serial imaging to really see what the effect is and whether that effect is a transient effect, as is seen in sepsis, where IL-6 is also upregulated and you get myocardial depression that tends to recover over time, or is this something that is a permanent consequence of CAR T-cell therapy?
Bonnie, if I may jump in as well. Yeah, I concur wholeheartedly. I think that while there's another area where there is overall a dearth of evidence, the evidence that we do have, including from this study, really points to this being a secondary effect related to CRS more than anything. I would say that I'm always a believer that semantics matter, and the term MACE, when it's used here, probably does mean something a little bit differently than when we normally think about the term MACE. I think Anju was sort of getting at this as well. We talked about, it said in the study, 22 cardiomyopathy events, one of which was stress cardiomyopathy. I don't know that I'd agree with that. I think that probably a lot more than that were from stress cardiomyopathy. The fact that the mean ejection fraction was 49% at the time of the so-called MACE, for those who had echoes, would suggest, for one, that we're not talking about huge LV dysfunction in most patients. And when you consider all the other things that are going on with the hypotension associated with the CRS, as we heard about the fluids and other resuscitation, and when the definition of symptomatic heart failure was symptoms of heart failure, which, gosh, that's going to be hard to tease out in a sick patient like this. Clinical signs of heart failure on exam, well, that can be just signs of extra volume, which these patients are going to have. Laboratory or imaging or radiographic findings of heart failure, well, again, it's not going to be uncommon to have some degree of pulmonary edema, which may not even be all cardiogenic in these patients, and BNP elevations. and an initiation of new treatment for heart failure, which can be diuretic. So it's a pretty broad definition. I think the reality is that most of these patients who develop LV dysfunction, it probably is quite transient. At least the handful of patients I've seen in follow-up have tended to be just this patient's bad CRS, and if they survive it, they fully recover their ejection fractions or close to it. So it's really important, I think, to have this extra data here to really tie it to CRS, but I don't think it represents a true direct cardiotoxicity.
Thanks, Ron. And I think you raised a number of really excellent points that we also struggle with in the field that we hope to overcome through our continued science and research. And that goes to accurate grading, accurate definitions, harmonization of data collection, and also, as Anju also alluded to, and Tom, just careful data collection, imaging, biomarker, systematic, and some type of longitudinal prospective fashion. I know Arjun Ghosh is also on the call, and I don't know if he's still on, but if you can elevate Arjun to speaker, and maybe he can also make a comment about the work that he's doing in prospective monitoring. In his recent review article, he also published their algorithm that they're using to help further define toxicities in this population. Arjun, are you able to make a comment? If not, we can also open it up to others. Ludmila, tell us about what's happening in Brazil and exposure to CAR-T and what you folks are all doing.
Bonnie, thank you. In Brazil, we don't have yet CAR-T cells available. Only one university, the University of Ribeirão Preto, has done a few cases, but we don't have the technology, neither we have now grants available to get it. But we are following up your studies, and I would like to add a few comments about this because 1 month ago in the European Heart Journal, a group of Norway has shown that the interleukin-6 antagonist tocilizumab can decrease the troponin after acute coronary syndrome because the inflammation is the driver of the elevation levels of troponin. So thinking about the cytokine release syndrome related to the CAR-T cells, maybe thinking about tocilizumab or other drugs which may block the increase of the levels of interleukin-6, maybe decrease the occurrence of heart failure and other clinical events. Maybe we should try to address how much and which point how we should prescribe these patients with this kind of drugs. In COVID-19 patients, patients who now have developed so much pronounced inflammation, we have used these antagonists, and maybe this can decrease the occurrence of cytokine release syndrome. So I'd like to listen to you about the opinion of how to use these drugs in this setting.
Does anyone want to take that, maybe the oncologist in our group, about the use of TOSI to decrease inflammation, Katie or Saro or Anne? And in the meantime, maybe also David, if you could unmute Arjun, because he's still on and would like to make a comment about his protocols.
Saro, this is not my area of expertise. Do you want to make a comment?
I think that we're going to be increasingly comfortable using TOSI. So that is definitely going to be used for not just for the cardiac purposes, but as well as for the systemic decompensation that we see in a lot of our patients. I do want to make one comment though, is that CAR-T is an emerging field, and you know, it started off as something that we primarily use for patients with acute leukemias, acute lymphocytic leukemias, or ALL. It's evolving to be used much more so in the non-Hodgkin lymphoma world, and then soon in the multiple myeloma and solid tumors, et cetera. And I would just say it's really important for us to think about that each of these are going to have different treatment approaches up front prior to CAR-T. So, with the ALL patients, we'll have very little anthracycline exposure. I mean, lower doses. You'll have the non-Hodgkin lymphoma patients will have much greater. You have the checkpoint inhibitors that was alluded to earlier for some of the other lymphomas, and the myelomas with their own unique cardiovascular issues. So I think having a baseline assessment of cardiac function before CAR T is so imperative. And if we have a large enough number of individuals where we actually have the baseline cardiac parameters phenotyped, it's really going to help us in terms of understanding the sort of the risk prediction modeling that we need to do to understand who's going to get into trouble. So I would just strongly urge prior to CAR T to make sure that all of our patients are actually getting appropriately cardiovascularly phenotyped before we actually stress them physiologically the way we do.
Great, thanks, Sarah. Thanks, Katie. Arjun, did you want to make a comment?
If I could add to what Sarah said, I would stretch that even further, Sarah, and say that everybody prior to CAR T should get a NT-proBNP and a troponin measure, similar to what probably should be done in people who are about to start checkpoint inhibitors. Is they should just get a baseline evaluation. Not that I would do in many cases I wouldn't do anything about it, but it's also good to have that reference range should any clinical questions arise later in their care.
Thank you.
Hi, this is Arjun Ghosh. Thanks, Bonnie, for the invitation to comment. Great talk, great discussion so far. To follow up on our prospective work looking at these patients at University College London, I think I agree definitely with all the speakers that a very good baseline assessment is required in terms of both echocardiography, even potentially biomarker NT-proBNP and troponin. And I also agree with the point made by Saro that although maybe in the future it will be different, but a lot of these patients, they've had 5 or 6 lines of potentially cardiotoxic chemotherapy beforehand. Cardiac function at baseline may not be normal. In the patients that we've seen thus far, the majority of these are probably, have some kind of reversible phenotype. And again, that may allude to the fact that this CRS may be some kind of pan-inflammatory stunning of the myocardium, not necessarily a direct permanent cardiotoxicity. But I think that given that this is still an emerging area, especially in adult patients, the jury is still out as to what the long-term implications are of these changes and whether we need to kind of follow these patients up long-term. But that's some of the things that we are doing locally. Thank you.
Great. Thanks so much, Arjun. And so, unbelievably, the hour is up. I had a phenomenal time talking with all of you. I learned a great deal. I want to thank you, all of our authors, speakers, and panelists. Thank you, all of our participants, for joining us today. And I look forward to hosting our next journal club as well in a couple of months. Thank you all, and have a wonderful day. Thanks.
Thank you.